I am joined by Tole Nayata, who is an Internews pandemic media mentor based in Nairobi, and he's going to be monitoring the questions as you type them in the chat box, and then he will pose them to our speakers. Before we get to our speakers, though, I'd like to show you a video. There's this program called Viral Facts we want you to know about. Viral Facts Africa. It's your home for accurate, fact-based health information. They work with fact checkers and health experts across Africa to debunk misleading health claims. Viral Facts is the public face of the Africa Infodemic Response Alliance, a network of trusted public health institutions and fact checkers working to make scientific, fact-based health information highly visual, vibrant, and shareable on social media. So we'd like to just play for you just one sample of the kind of presentation you can find on the Viral Facts Africa website. Let's have a look at that video now, if we can, please. Great. We will share the contact info for Viral Facts at the end of our dialogue today. So now I'd like to move on to our first speaker. Cyrille Hommell is a data scientist with the RCCE Collective Service. Cyrille's here to take us on a tour of the Covid-19 Behavioural Dashboard, a great resource to get the latest data on how societies in your country are responding to the pandemic. Cyrille, welcome to Media Dialogues, and I'll hand it over to you now.
Hi, Wayne. Hi, everyone. Let me share my screen. Let's go to full screen. So here is our country dashboard. We've been gathering data for months, and we've organized it around 5 dimensions, which you can see at the top as navigation tabs. So we've looked at information, knowledge, perceptions, practices, and social environment. Then within each dimensions, we've defined some indicators. So here we're looking at practices. And for example, we're looking at protective measures, vaccine willingness, self-medication. And then for some indicators, we've added some details with sub-indicators. So for example, for protective measures, we're looking at hand washing, mask wearing, physical distancing. What we display currently on the screen is the latest value available. But if you move the pointer over the value, we see more details. So we get the latest value, its date and its source. We also display the confidence interval, and we also show some trend. And here the data seems to show that in Kenya, the mask wearing tend to be on the decrease. And to add and to show a little bit perspective, we're also displaying quartiles as the little triangles. So for example, the black one here is the median, and its value is showing up now. It means that half of the country mask wearing is below this value and the other half is above. Yeah, so that's the main frame is all data, but to add more perspective to that, we also display other data sets. So for example, on the left-hand side, we display a country profile with key figures, especially around health system. And we also display some more COVID-19 specific figures like stringency, for example, which is the level of restriction in the country. And again, by moving the pointer, we will see more information. So here it's a lot of information, but in pink, it's the measures around stay at home, and in blue, the mask policy. So we can see that in Kenya, currently mask wearing is mandatory everywhere, whereas there are no stay at home restriction. We've also got a COVID-19 risk index produced by Inform, and the level of economic support provided by the country. So that was these 5 tabs organized the same way. We've also got another one, which we've called tools. And this one is used to look at 2 indicators at the same time and compare them. So for example, we could look at susceptibility, which is how likely people think they are to contract the COVID-19. And if we display it against the number of cases, we can see a bit of a correlation, which doesn't come as a surprise. And it's quite interesting to look at the latest values. So in December, with the possible impact of Omicron, with the number of cases increasing a lot, and the perception of risk by the population, which is increasing as well. And sorry, going back to the main tab, I forgot to show you another data set, which is the epidemiological data shown at the top with the number of cases. So again, we can see a peak there. Sorry, technical glitch. So number of cases here with a bit more detail. So in blue, we show the number of new cases per month, whereas the green curve will show the cumulative number of cases. We've got the same for the number of deaths here. So we can see that despite the increased number of cases, the number of deaths is luckily quite low. And we also show the vaccination rate. So the top curve, the green one. And the last function I wanted to show you is this little icon, which is the data export. So here, if you are a little bit patient, the data will show up as a CSV file, and you can access all the data at granular level. That's not the right, that's the one. And it's all the data we're displaying in the dashboard, but even a little bit more, as we're only showing the data for the overall population, but here in the data set, you can see disaggregated by age, by gender, living area, health workers. And it's the data at its most granular level. So you can, for each data point, you will be able to see the source, how the question was asked, the replies that were taken into consideration, And you can also access the source directly. So if you want to dig further, you can access the raw data. Here's the value, and we display all the time.
Cyrille, sorry, we can't see anything. It's just a white screen.
Did you see the dashboard before?
Oh, yes, sorry.
Okay. Sorry. Let me. I guess it's better now. So that's the different categories of population you can see data for. So by age group or gender, the column with the data source and the link to access it. Here's the question and the reply shown at the end. And finally, the value and the error margin, which is mainly driven by the sample size and the sample methodology. So that was the dashboard in a nutshell. I don't know if anyone has any question.
Thanks, Cyrille. I'm just wondering, that this is kind of a broad question, but is anything in these results that you're tabulating, has any of this surprised you? Do you see any unexpected trends happening, particularly with the arrival of Omicron?
Not necessarily surprising, but yeah, we run a little analysis. So here on this map, we display the date when Omicron was first identified in each country. So we can see that a lot of countries in ESAR have been impacted, and we zoom on a few countries. And for each country, the blue curve is the number of cases. So it's exploding everywhere, more or less. The green one is the perception of risk by the population. And we can see a strong correlation in most countries. The feeling of risk has increased. The other ones are displayed by gender, and female tend to feel the risk a little bit more. So yeah, that was an interesting result. It didn't, however, translate into stricter respect of the protective measures, but the risk perception was a strong result.
Oh, okay, yeah, I was going to ask if people were feeling they're more at risk because restrictions had been lifted, curfews had been canceled and things like that, which we have seen in other parts of the world, and there is a lot of concern. The WHO yesterday announced that they're seeing a worrying increase of COVID deaths, and this at the same time that we were being told by the science that yes, Omicron is more transmissible, but is less deadly to the vaccinated. So yeah, it's interesting to see that the death counts are rising, even though, and people are, and as the dashboard says, people are feeling at risk, and yet they're also not being as careful to protect themselves. So I'm not sure what that tells us, if there's just an overall COVID fatigue that's settling in, and we have to be very careful of that, because as we can see by the WHO statistics, this is still a very dangerous variant of COVID-19. I think we'll just add that, of course, I think you've shown this, but this is this is very country-specific information, so journalists on this call, you can go to your country if you're covering one country and find the latest COVID data using this dashboard. I think we're going to move along. We're still waiting. Unfortunately, we're still waiting for our WHO representative to join the call. So I think he is having
Wayne, I've been on the call. Issues. I'm here.
Oh, my apologies. Right, you're there, Ope. Okay. I didn't see your name, or I didn't see you show up on the screen. Welcome. It's great to see you. First of all, thank you, Cyrille, for your presentation.
I'm here. For some strange reason.
And people with questions after Ope's presentation, we'll take questions for both Cyrille and for Ope. Okay. So now, Opeayo Ogundiran is an epidemiologist working with the Emergency Preparedness and Response program at the WHO Regional Office for Africa in Brazzaville. And the past 2 years, the majority of his work has been to strengthen epidemiology and surveillance for COVID-19 and other infectious diseases in the 47 member states of the WHO Africa region. So Ope is here to give us the latest on the Omicron variant. Ope, welcome back.
Thank you very much, Wayne. It's a pleasure being here again. The last time was fantastic. I hope this will trump that. So today I would make it pretty short. The last time we had a long conversation, which I felt lasted a little bit too long. So today we'll make it really short, focusing specifically on a few points. And then I guess we'll be able to speak a little bit more, taking more questions or clarifications. So today, over the next few minutes, maybe about 5 minutes, I'll talk about the 5 things we need to know about the SARS-CoV-2 Omicron variant as of today. So like Wayne said earlier on, the Omicron variant was reported sometime in November. So about 6 weeks now, we've had this variant be the most trending thing about COVID-19. But ever since, the variant has been identified in at least 171 countries internationally. It has rapidly outpaced Delta. Delta used to be the big variant before the advent of Omicron. And Omicron variant has displaced Delta essentially as of today, where even at that phase where anything COVID today is possibly Omicron. And the reason is because the variant has a significant growth advantage over Delta, which means if these two, just to put in plain terms, if these two variants are put in a same environment, Delta has a better rate of multiplying, higher than that of, Omicron has a higher rate of multiplying than Delta, and that way, evolutionarily, it displaces Delta. The risk is still really high. What we've continually seen, and like Wayne rightfully signposted us to, is we're beginning to see this narrative of a of a mild disease. Is it less severe than Delta? Yes, it is. It's less severe than what we've seen. And when we talk about severity, moving on to the next point, we're talking about the likelihood of people developing diseases that land them in hospitals. So when we look at the data and we compare the likelihood for Omicron to do that compared to the previous variants, there's a less likelihood of that happening. However, because of this notion, the information has in many places been taken as Omicron is mild. It is not mild in any form. And I think today's conversation will be a little bit more focused around, instead of the technical conversation we had last time, it'll be more about, okay, so what's happening with Omicron as of today? What news is out there, and how can we as journalists pass on the right information? So the first thing we need to notice is it's not a mild disease. Omicron still gives the full spectrum of any of the variants, right from the parent variant 2 years ago, till date. So people from asymptomatic to symptomatic to mild, the mild form, all the way to severe disease needing hospitalization, oxygen therapy, and even death. So Omicron can do any of those. The other thing we need to also keep in mind, even though we have the data is showing that the variance is less, the chances of ending up in a hospital, developing severe disease is less compared to the other diseases, the other variants. We still don't know the position of post-COVID, or what we call long COVID. And those are the long-term sequelae that develop beyond the acute phase of COVID. What we've seen is it's not directly correlated to the severity, which means even people with mild symptoms have reported post-COVID sequelae. And because of that, we still don't know the situation beyond this quote and unquote less severe outbreak of the variant. So some things to keep in mind as we keep the conversation going. The third point is vaccination. Big topic. We need to keep on emphasizing the fact that even in the face of Omicron, even in the face of reports of lowering of the immunity conferred by vaccines, Omicron is still very effective against these hospitalizations and deaths. And I think it's very important in our setting today, in the African region, in the ESAR region, where we are beginning to see quite a lot of hesitancy to receiving the vaccines. There are these conversations about, well, Omicron is really, really transmissible. In the end, maybe we all will get Omicron. So why bother myself standing in a queue for such a long period? Well, the big reason is because, one, it reduces the chances of you ending up in a hospital, needing oxygen therapy, and probably dying from it. There is some evidence that's being reviewed that shows that even though the is not as great as developing serious disease, there is still some. Sorry, can you just confirm you can still hear me? I think my internet is a little bit shaky here. Hello?
Yes, we can.
Yes, we can hear you.
Okay, great. Thank you. So I was talking about vaccines. So the big message behind this is, as of today, especially in the context of the new ramp up of vaccines being landing in our continent, the amount of hesitancy that's being touted about, and especially this misconception of Omicron being a milder form of COVID. It's at this point in time we need to keep on pushing that message out there that vaccines are effective, they are safe, and they reduce the likelihood of severe disease, hospitalizations, and death, which actually are the ones that are the big problems. Big problems for individuals. We don't want to end up in a hospital bed. Big problems for governments, because that overwhelms health infrastructure and resources. Say, for example, the same beds that could have been used for other diseases or outpatient services where life-saving immunization for kids or antenatal care could have been going on. But because of that, because of this big burden, we then need to transfer resources. So smaller picture, larger picture, as we tell the story about vaccination. The next big point, another big misconception that's coming out quite often is that where we've seen the last variant, or we've turned the curve of the serious variant, so to speak. Omicron is milder, and from evolution, it means with every new variant we have, if we have another one, it's going to keep getting milder. That's not the case. We cannot tell what the next variant would be. We don't know. What we know for sure is it's going to be more transmissible than Omicron, because it would need to displace Omicron to be the new variant of concern. But we don't know if it's going to be a more severe form. Say, for example, it's Omicron plus, and now it has a more severe form. We don't know that. So we need to emphasize the fact that this is not going to be the last variant we're going to see. The next variant, there's no telling whether it's going to be a worse variant or not. So we still need to keep this conversation going. People need to protect themselves. And that passes me on to the last point about public health measures. The things we've done right from the beginning of the pandemic. Physical distancing, the use of well-fitted masks, covering above the nose to above the chin, because we have a lot of variants of how people wear their masks these days. ventilation when we can, ensuring these different public health and social measures are still relevant today. So I guess those would be the 5 points that I would like to highlight today as a pointer for our conversation as questions come through. I would leave this last slide on, and it's an infographic to the left side of the slide of what we need to know about Omicron now and how we can protect ourselves. I think the slides will be shared with all of us. But for our information, especially as we pass this information on through social media, I think this is a nice snapshot of what we can then use as a tool to pass on the information. That'll be all for me, Wayne, concerning the presentation, and I'll be happy to take questions and continue with the discussion after. Back to you.
Thank you very much, Ope. I believe my co-moderator, Tole Nyata, you have a question for Ope, Tole?
Yes. Good afternoon, Dr. Ope. You've talked about long COVID. This is a word that's more and more being thrown out there. So what is long COVID and what are some of the symptoms?
Thank you very much, Tole. And I think it's an important question to ask, especially like you rightfully said, it's showing up more and more in conversations. Essentially, what we will call long COVID or post-COVID, and if we know anybody who's got COVID, or if maybe in the past we also had it at some point, there are a series of symptoms that come as a result of being infected by COVID outside the acute symptoms. So the immediate acute symptoms would be difficulty in breathing, the cough, the fevers and the likes, which would usually resolve, as long as the person doesn't end up on the other side, would usually resolve after a few days, maybe about a week or two. But then there's this sequelae of residual symptoms that usually set in. So things like acute loss in blood pressure, which could lead to imbalances or falling. There's some loss in sensory use. Some people say, for example, had COVID, they can't feel, they feel this pin feeling at the bottom of their feet. There's this shortage of which means things that they could do in the past, maybe run a marathon or even have a regular jog, it's now difficult for them to do it now. Now, these are symptoms that take a long period. It's beyond that initial phase of the acute COVID infection, where in 2 weeks things resolve. But unfortunately, there are these myriad of symptoms that remain in many cases, not in all cases, but in many cases, there are these symptoms sometimes quite debilitating. Some people still have loss of taste and smell for many months after. So those group of symptoms beyond the acute phase are what we refer to post-COVID or long COVID. Now, it's still very under-researched, and we can understand why. We're in the middle of a pandemic, it's an emergency phase. People will be more interested in what's happening now. But there are a lot of reports of people still showing up to emergency rooms and clinics post-COVID to deal with other symptoms. And for that, research is beginning to build up, but we don't know the extent to which. It's still a little bit too early to say, is this going to be a lifelong sequelae? Is it after a year? Is it after 3 years? Will it transition into anything else? Will it regress? So that whole group is still being researched. And I guess the scary part is it's not only in the severe. We'll usually see this type of sequelae amongst people who have severe symptoms of other diseases. But what we've seen in COVID is even people who had mild symptoms sometimes come down with these post-COVID symptoms. And that's why it's a little bit scary. Tole, I hope that answered the question.
It did. Thank you very much.
You're welcome.
Wayne.
Okay, yeah, I have a question. I was really fascinated to hear you say that the next variant after Omicron, I think we're safe in thinking there might be another one, has to be even more transmissible than Omicron itself, which is incredibly transmissible because it will have to overtake Omicron. how far can this go? I mean, how many more times can we have more transmissible variants coming onto the scene, do you think? Is this could go on for a long time? I think, is Ope's screen frozen? Oh my goodness.
Yes, I think we lost him.
We just lost him. I wonder, my other question, actually, I think maybe I'll challenge Cyrille with this question, if you don't mind, Cyrille. Clearly, from what Dr. Ope is telling us, vaccination is the key, and we all know this. This is well-established fact. Vaccination is the key to keeping us from getting seriously ill from the current dominant variant, Omicron. But what is the vaccination situation now in East and Southern Africa? Is it a question of access? Is it a question of hesitancy? We know rates are low in many countries in the region. Can you kind of give us a picture of what the situation is, Africa, East Africa and Southern Africa region-wide?
So yeah, it's data we're covering in the dashboard. So, and it varies a lot from country to country. Here we're displaying Kenya. So vaccine willingness is very high in Kenya. Well, that at least that's what the data is showing. However, the vaccination rate is quite low. Here at the bottom curve, we'll show in green the number of doses administered, whereas the blue one shows the number of doses supplied. Given the vaccination rate is very much on the high, it's most likely a supply shortage. It's hard to tell, and we will need much more analysis, but at least with a vaccine willingness so high and vaccination rate so low, it's most likely a supply shortage. I don't know. We can pick other countries. Let's look at, I don't know, South Africa. So it's a bit slow. So here again, vaccine willingness is still high and vaccination rate much higher. But it seems to be slowing down again, most likely a supply shortage.
I see.
We haven't shown it here, but we've also got a global dashboard, which is quite good for country comparison. Maybe we can add the link if there's a follow-up email. I'll try to show you.
Absolutely.
I'll try and show it. So I'll pick vaccine willingness and filter on ESAR. So globally, vaccine willingness seems to be quite high, but you can see clearly countries where it's lower. We're missing data on Namibia, so it's maybe not a good example. Zambia is most likely the the data, there's a lot of noise, but at least this is a good tool to compare country by country.
Yes. Excellent. Tole, I think you had a question.
Yes, I see Dr. Ope is back. Dr. Ope, I want to ask about the transmissibility. The Omicron virus is very transmissible. And is it that maybe the current protective measures are not enough? Should we maybe change the mask? Or why is it that it's more transmissible? And also, another question is with regards to the isolation, the recommendations that was with regards to isolation. We are seeing we have a very transmissible variant, and yet the isolation period has been revised downwards. Why is that? Thank you.
Okay, thank you very much, Tole, and apologies, everybody. We had this power outage here, which cuts me off for a moment. So regarding the first question, why is it more transmissible? I guess the easy way to answer that is just like any living organism, viruses would find a way to always survive. So what viruses would usually do is to change their genetic composition and in order to live longer, essentially. Now, for disease-causing viruses, especially those that affect humans, it then presents in different ways. So for the Omicron variant, as part of its mutation, its change in genetic profile, it developed to a form whereby it's more efficient in infecting human cells. It binds much better to receptor sites. And that way, as an organism trying to survive, it means the more of it is out there, and then its progeny would stay longer in life, so to speak. So that's where the transmission comes from. The increased transmissibility comes from. The organism became more effective in infecting human cells, and that's why it made it a little bit easier for it to transmit. Regarding protective measures, yeah, it's one of those controversial topics that we've had to deal with over the past few months. A lot of the decisions to reduce the number of days are driven by, one, the economies of keeping people at home for long periods. I'm sure you remember in the beginning of the pandemic, we were talking about 14 days at least. But at the time, it was fine to close borders and shut down airspaces and the like. So a lot of those decisions to reduce the number of days are weighed against, well, one, Omicron being not as severe outcome-wise, and also a lot of these economies whereby, is there any difference between keeping people at home for 10 days and 7 days and the like? It's not very, very linked epidemiologically to what we're seeing with the virus. The virus, the time for transmission, optimal time for transmission still is between 7 and 10 days. That hasn't changed from the beginning of the pandemic till now. But I'm sure you can understand how governments, ministries of health have to balance these difficult decisions on how long. So somebody who has stayed at home for 7 days compared to an extra 3 days over the past few months, has that shown that 3 days is as effective? Can we trade off that bit so that we can trade off the economies of scale and the likes like that? So it's quite complex. There is no clear science behind reducing it. As a matter of fact, the science opposes it quite a bit. But as we know, it's not just science that policymakers, decision makers alone consider for these decisions.
Okay, thank you. Yes, it does. Thank you very much. There's that question you've answered in the chat. I'd be happy if you can tell us, because that's a common question, not just from our colleague in Rwanda. It's a question that everybody asks. Can we identify if we have a particular variant? Are the symptoms same or different?
We've seen right from the beginning of the pandemic, whether it was the wild type, the one identified 2 years ago, alpha, beta, as a matter of fact, the whole Greek alphabet all the way to Omicron, the symptoms have not changed. We have not seen any change. There were new symptoms, like I think it was with Delta, the loss of smell, the loss of taste with Delta, that was more pronounced. It was still there in a few cases previously, but in Delta it was a little bit more pronounced. But we have not seen any significant change in symptomatology. That's one. Secondly, we cannot identify what a variant looks like from symptoms. It has to go through gene sequencing for us to know which we're dealing with. So I guess the short answer for this long ramble I'm doing is no, we can't differentiate the symptoms. They are the same exact symptoms that we've seen from February 2 years ago that we're seeing now.
Okay, thank you very much. There's a question from Francis Murezi to Cyrille. Francis is asking about Kenya-specific data in the dashboard. He's requested that you give them as much data as possible. Cyrille?
Yeah. So let's move on. I'll share my screen again. And so the question was to show the data that's available, right?
Yes, that
Yes.
was the question.
Yes.
For Kenya, you said, right?
Yes.
So let's go through the indicators quickly if you want. So in terms of information, we will look at whether people are looking for information and the items they're interested in, whether they have access. Sadly for Kenya, we have no data. Whereas whether they're satisfied with the information they receive, the sources they trust, and the risk of fake news. Next dimension is knowledge. So we will look at whether people are aware of the symptoms, aware of the transmission modes, if they know how to protect themselves and the community, and lastly the health protocols. Again, sorry, we haven't got data for Kenya on these last three indicators. The next dimension is perception. So susceptibility is how likely people think they are to get the disease, how efficient they think that the protective measures are at individual level and for the community, whether they think that health facilities are safe to go, the risk of stigmatization and fairness of the measures, and practices, we've covered them already. Protective measures, vaccine, self-medication, and behavior. And the last one is the social environment, whether people think it's easy to access healthcare, stigmatization. Again, this one, the previous one was if they felt stigmatization, and this one is whether they observe it. These four items, we haven't got any data. This one, community engagement trust, is how they trust the health authorities and the government. Economic impact, split as a straight economic impact and food insecurity, and the psychosocial impact as itself. And we've also included kids missing school. So very quickly, that's all the indicators we're measuring. And the download function will export all of that.
Okay.
Excellent.
There is a question, Wayne.
Oh, go ahead. Sorry, go ahead, Tolly.
Say in Southern Sudan, people are dismissing Omicron as normal December influenza. The characteristics of the virus is blurring. Besides, and also they add, besides people refusing to take vaccines because those who are vaccinated were getting COVID again. What is your comment about this, Dr. Ope?
Okay, thank you. I think there's an important question two questions to address. So the first one, regarding people dismissing Omicron as the regular seasonal influenza that we see at the end of the year. So first, it's extremely hard to differentiate the two from symptoms because many of the symptoms that we've seen from influenza are also symptoms that COVID presents with. So for example, things to do with difficulty in breathing, rhinorrhea, any of the upper respiratory tract infection symptoms would be represented on both. What is different is the likelihood and the propensity for COVID to develop severe disease compared to influenza. But then again, Omicron, also being a less severe form of COVID-19, also then adds an added layer to complicate that. What we've tried to advise people is to treat the so-called December influenza as COVID until proven otherwise, which means the moment you have symptoms that look like either COVID and or the seasonal influenza, please go get tested for COVID. So it should not be dismissed. That might be the first pointer. And luckily, we really hope the test will come out negative, but you would rather err on the side of testing negative than not testing at all and then being positive for COVID and then developing more severe symptoms. So I would say as we go back to communities to talk to people, let's make that quite clear. It might be the influenza, it might not be the influenza, but we'll never know until we test. And the reason why we would want to test is for us to err on the side of detecting what the worst one and protecting ourselves early enough and not taking the risk of it being the other way around. The second part of the question says people are refusing vaccines these days because a lot of people who had vaccines in the past then came down with COVID-19. I mentioned it last time, and I hope we get to emphasize this more and more because it's something we need to tell people all the time. The vaccines are not designed, they were not initially designed to stop chances of infection. They were designed to reduce the burden on our systems. And what that does is to reduce the likelihood of developing severe diseases, severe symptoms, and that could lead to death. The way I describe it is, we at some point in time have these funny upper respiratory symptoms where we're blowing into a handkerchief or something like that. But do we actually get scared that those type of funny December influenza would end us in an intensive care unit where we need to depend on oxygen? No, we've never really had that fear. Now, that's what the vaccine does. It takes Omicron or COVID from that disease that can end us up in the ICU to something to the level where we would not be scared to end up in the ICU. And that's why people should go ahead and get vaccinated either way. Having said that, the data is showing that even though the likelihood of contracting COVID, even if you were vaccinated before, is actually there because the vaccines were not designed to stop the spread. We are still seeing some level of immunity being confirmed, which reduces this likelihood of transmission. So even though it might not be as efficient as protecting severe disease and death, there is still some evidence being shown that it does reduce the chances of spread. But no, it's not designed to stop people from getting COVID. There would be people, quite a lot of people who have collected the vaccines that will still end up with COVID. The only difference is the likelihood of them ending up in an ICU and probably dying from it is severely reduced. And I think this is something we need to tell the story a little bit more because these are the things that lead to this type of vaccine hesitancy if it's not clear. So I guess that's a call to action for all of us on this call.
Thank you very much. Absolutely. I second that. Before I take it back to Wayne, Francis, we will definitely link you up with Cyrille, and all the best in doing your story. Wayne, back to you.
Thanks, Tole. Yeah, unfortunately, I think we're at the end of our hour, so we're going to have to wrap things up. But as we do, we'll put on the screen now the contact info for Viral Facts and for the RCC Collective Service COVID-19 Behavioural Dashboard. So you can jot down those details. Definitely, those are two resources I hope that you can make use of in your reporting. Also let you know now that we've recorded this talk, and we will be sending out to all of our journalists a link to the recording. So if you're doing stories based on this, you'll be able to get your quotes absolutely exact. And in the next following days, we'll also send out audio excerpts of today's media dialogue, and we'll be sending those out to our journalist network via WhatsApp, just to make sure everybody who can get this latest data on the pandemic, despite whether you're able to Zoom in or not on us. So as always, we want to hear from you about how you use this information in your stories. So if you could send us some stories that you write based on this, or videos or audio, whatever, we'd love to see that, just to know that the information that we're providing is being useful to you. And we also would like to hear from you about what topics you would like us to address in future media dialogues. So please just keep in touch with us. I'd like to thank very many thanks to Opeayo Ogundiran and Cyrille Hommell for joining us today. And until next time, for Tole Nyata and the RCCE Media Working Group, I'm Wayne Sharp saying thanks for joining us and stay safe.
Thank you, everybody. Bye.
Thank you. Thanks, Dr. Ope. Thanks, Wayne, Tole.
Bye.